Just want to give everyone a warm welcome. My name, for those of you, if there's anyone who doesn't know me, my name is Rebecca Ganan, and I'm an associate professor in the School of Nursing at McMaster University. I'm the scientific director of the Aging Community and Health Research Unit, the co-lead of the McMaster Collaborative for Health and Aging, and I am the nominated principal investigator who works with a terrific team of co-principal investigators and research team members on the Embolden study. So this webinar today is jointly hosted by Embolden and the Collaborative for Health and Aging. And I think in particular, for example, Embolden, as many of you know, is a trial to promote mobility in older adults who are living in the community. So through physical activity, healthy eating, social participation, and system navigation. And so we co-designed what that new program would look like and are just towards the end of wrapping up the trial. So we have a few more sites to go, but we're closer to the end of the finish. So we thought that this was a really timely opportunity within the research program to think about scalability assessment. It's also well timed because we have the opportunity through some other work that we've done through our Aging Community and Health Research Unit, where we've already gone through this process of the trials and are looking at partnering and how do we move forward with integrating the best research evidence into practice and helping to inform some of the work at Scarborough, in the Scarborough, Ontario Health Team, and think about how we can inform their integrated care pathways. So similar to that work that Melissa is going to talk about, Embolden is also an integrated care approach, a collaboration between the rec department and public health and primary care to jointly deliver a new way of supporting older adults who are living in the community. So with that, so I just wanted to do a little bit of context setting. Before I go on to introduce Melissa, I just want to acknowledge that we're really grateful for the support of all our partners and also for the generous funding that we have through the LaBarge Centre for Mobility and Aging, the Canadian Institutes of Health Research, the Public Health Agency of Canada, Mira Dixon Hall, and as well through the McMaster Collaborative for Health and Aging through the Ontario SPORE Support Unit, so the Strategy for Patient-Oriented Research. So really grateful for all that support because it really helps us to do what we do, but all of you are also an important part of our work as well, because without our partnerships, we would get nowhere near as far as we have. So thanks for all your commitment and your interest to this work. Without further ado, it is my great pleasure to introduce my colleague and friend and collaborator within the Aging Community and Health Research Unit. She's one of our investigators and an early career researcher and who already has so much expertise and adds so much value to all the work that we do. So Dr. Northwood is an applied health services researcher and a previous CIHR Health System Impact Fellow. She conducts collaborative research through strategic partnerships with older adults and health and social service providers to improve the health and well-being of older adults. Her research program seeks to enhance quality and improve the culture of practice environment and advance health system transformation through a learning health system. So Melissa joined us full-time in the School of Nursing in 2020, and prior to that, she had a lengthy practice career across health sectors from acute care to home care, always focusing on older adults with multiple chronic conditions. So we're really pleased to have Melissa joining us today. And Melissa, I'm going to turn it over to you. And for those joining us, I see you all have mute on right now. So we just ask that you keep mute on while Melissa's giving her presentation. And then there'll be an opportunity for discussion and questions at the end. So Melissa, over to you. Thanks so much.
Thank you. Thanks, Rebecca. Hi, everyone. I'm just going to get my slides going. Success? Yay. Thank you. Well, hi, everyone. Thanks so much to the Embolden team for inviting me to talk to you today about assessing the scalability of integrated care programs for older adults. And I'm hoping to share some of the lessons we've learned along the way in this journey. And as Rebecca said, I'm newish to the School of Nursing, but certainly translating evidence into practice has been very important to me in my clinical work as an advanced practice nurse, and certainly challenging to translate best practice and evidence into practice, especially when I was working in home care working in the context of clients' home with limited resources. Sorry. So now on the other side, as a researcher interested in developing and implementing integrated models of care for older adults, thinking about it from a different way, how to translate lessons that we learn in research across kind of the complex systems of care and health and social care. So learning about the scalability assessment over the past couple of years has been a really practical research method I've found to inform this work. So I'm pleased to share some thoughts with you today. First of all, I'm here at McMaster today, and I'd like to acknowledge that we are located on the traditional territories of the Mississauga and the Haudenosaunee nations, and within the lands protected by the Dish with One Spoon Wampum Agreement. Just like care of older adults is a team sport, research in this area is as well. And I have so many people to acknowledge that have been came before me and were involved in these projects that we'll be discussing the scalability assessment of today. And I see many of you on the line too, which is exciting. And also acknowledge the funders of these projects. And here at the bottom is our current research team for the current scalability assessment that we're doing. And we were funded by Ontario Health, Core Health, for that work. Okay, so this is what I'm hoping we'll achieve today. We'll talk about scalability assessments and what they are. I'll share information about a tool that we've been using to assess scalability in the context of these two research examples. And then I'm hoping together we can reflect on the role of scalability assessments in knowledge mobilization. Okay, so I'll start just with a few definitions of what we mean by scalability. And that's the ability of a health program or an intervention that's been shown to be effective on a small scale under controlled conditions like research to be expanded into routine practice to reach a greater proportion of the population while still retaining its effectiveness. And then the scalability assessment is a systematic process to assess the suitability of a health program or an intervention for scale up. And then scale up is deliberate efforts to increase the impact of a successfully tested health intervention or program to benefit more people and to foster policy and program development on a lasting basis. So assessing the scalability of promising programs is important because we know many interventions and programs are scaled up without supporting evidence, or sometimes programs and interventions that aren't working anymore stay and are translated into the health and social care system. So the results of this systematic process of the scalability assessment can be used to inform very local or regional planning activities. And ideally, it should precede the development of a scale-up plan, and then the next step would be implementing and scaling up. So here are a few of the intended purposes of doing a scalability assessment. And the thought is that this would increase the likelihood of an intervention from a pilot project that would be implemented to scale. And the WHO calls it, quote, beginning with the end in mind. So thinking about during that design and testing phase, what will it take for this intervention or program to live out there in the real world? So its purpose is to consider the fit of a new program or intervention with the local context in a very intentional and systematic way. And this helps to identify gaps that we may have in information that would be required to make an assessment of whether the program can move outside of research supports into practice settings. And it also informs decisions about how and where the intervention could best be scaled. There's a lot of information in the literature on scalability assessments that have been done in lower and middle income countries. This is kind of where this got started, most commonly in communicable disease prevention innovations. While in higher income countries, we do seem to focus on the development and testing of pilot programs. And I think this has limited our understanding how to scale up promising programs or interventions into routine practice. Okay, so this is the scalability assessment tool that we've been using in our work, the Intervention Scalability Assessment Tool, or the ISAT. And it was developed by a group of researchers in Australia through a literature review of implementation science literature and expert consultation. And they went through 2 rounds of user testing and revising and refining this tool. And then they produced a really comprehensive practical guide that honestly I have printed and carry around with me. And they generated specific questions to help facilitate discussion as well about the scalability. And they've kind of mapped through many important scalability components and predictors of challenges. And there was a recent review, I have it in the reference list at the end, of available tools to assess scalability. And the ISAT came out as considering most of the important scalability components and many predictors of potential challenges in implementation. So that's how we kind of came to choose it. So it's designed to make an assessment of the scalability of a program, think about the contextual factors that would help or hinder at scale up, identify if we need more information, and then provide a structure for determining if the program is suitable and scalable. So the developers, Milat and his team, they suggested that the tool be completed by a group of interested parties collectively with a range of experiences, including providers and researchers and policy and decision makers. And the tool can also be used in the pre-design process if you're designing a new program, and can be used to think about what would you need to consider with scale up in mind. So the tool itself is broken into 2 parts. So part A is really about the intervention or the program itself, and then part B looks at all the factors that would be involved in implementation. And as I said, each domain then has helpful questions to guide the team through the assessment. But they also have questions so you can rate the scalability of the program by the domain. And they pose these questions with a Likert scale from 0 to 3. So people working on the scalability assessment can think, how ready is this program to be implemented with respect to this particular domain? And they would rate it from 0, like not at all ready, to 1 being a small extent, 2 being somewhat, and 3 ready to go to a large extent is ready. And the guide also contains a section that walks you to thinking about how you might approach scale up. Would you be looking at implementing it in a vertical way, they call it, like across a whole system simultaneously, like say in a city or a province or even nationally? Or is it going to be more of a horizontal scale up where you're going to start with different sites and groups in a phased kind of stepwise manner? Sometimes that's not known ahead when a team is sitting down to decide. So that can be part of the scalability assessment, is working out what the best way to scale up might be. So I don't want to go through the whole guide with you because it is quite lengthy. There's 19 readiness questions, for example, but I wanted to give you a sense of the depth of the questions, and then the rating questions as well. So you can have a sense of this process that we've worked through with this tool. So here's the example for the first domain, which is the problem. And that's trying to get the group together to decide what is the problem and who is it affecting. and what is the impact on the health of the population. So here they're hoping there will be local data available to understand epidemiological impact of the problem, and then looking at what is current practice. So how does current practice compare and contrast with the new program? And then when thinking about this, then they ask you to rate. So is the problem of sufficient concern to warrant scale up of the program or intervention? So that's an example there. I just kind of selected a few of the domains. Here's A5, very important and sometimes hard to estimate, the intervention costs and benefits. So it's looking to collect information about were the costs of the intervention reported in the literature, are they available? And was there any evidence of those benefits outweighing the costs? And then the associated readiness assessment question, is there evidence that the benefits exceeded the costs? And that would be rated again from 0 to 3. Here, an example from section B, getting into some of the implementation issues around fidelity and adaptation. They're asking questions around, are changes or adaptations going to be made to the intervention or program prior to considering scale up? Would those changes have an impact on the intended outcome? And then how would the program or intervention's fidelity be monitored and maintained over time? And in this discussion, also taking note of what those potential changes might be. And then there are some questions around thinking about if the intervention or program was adapted, would it still be effective and in a favorable way? And what is the readiness of the system for being able to monitor and maintain fidelity if implemented at scale? I'll just show you this last example here is from the implementation infrastructure. And there are many, many prompts actually in this domain, because it's a big one, because it's referring to the infrastructure. What is it going to take to run this program? Is it classrooms or clinics or community centers, information technology equipment? And then it's looking at some of the operational requirements around training and education and monitoring feedback systems and so on. So here it's asking what the infrastructure requirements are and what would be the facilitators and barriers to accessing and maintaining that infrastructure and then sustaining it. And then the readiness question is how ready are the existing infrastructure? How feasible would it be to get from the existing infrastructure requirements to what's required for the program or intervention? Okay, so that just kind of gives a flavor of the tool. So now I thought I would move into talking about how we've conducted scalability assessments of 2 integrated care programs for older adults. So the first one was with the Community Partnership Program. And in this case, the scalability assessment was built into the project and proposed in the initial proposal, the initial planning for the project. And it was the final phase of the research. And the goal was to determine the readiness to scale up this particular program in 2 provinces in Canada, so that at the end of this study, the research team could provide policymakers and providers who are part of the project with information to go on to develop their scale-up plan. And then in the project that we're currently working on now, regarding the scalability of a transitional care stroke intervention, in this case, the scalability assessment was conducted after the real-world trial had been conducted. And in this case, it was at the request of our funder, Ontario Health, to determine the readiness to scale up the intervention in 3 community stroke rehabilitation programs in Ontario. And these were chosen to reflect diversity in geography, with being urban, rural, and northern. And also different team composition. One of the teams had a system navigator role, that the province is interested in strengthening system navigation and community stroke rehabilitation. And so in this case, the purpose was to provide Ontario Health or Core Health and the providers and leaders of these community stroke rehabilitation programs with an assessment of what factors would facilitate or hinder scale up in these settings, and hopefully provide some information to programs that are similar across the province. I just wanted to take a moment just to, at a high level, describe these two programs that we did the scalability assessments with. And the first is a community partnership program, which was a 6-month patient-oriented intervention designed to integrate primary care and community care services to improve the self-management of diabetes and multiple chronic conditions in older adults and their care partners, with a view to address gaps in diabetes care for older adults by taking a social determinants of health approach. And the core components of the intervention were based on best practice guidelines, but included care coordination, system navigation, community, and connections with the community exercise program as well. Similarly, the transitional care stroke intervention was also a 6-month program delivered virtually that was designed to complement standard care and outpatient stroke rehabilitation services to improve the quality and experience of transitions as people with stroke move through the system from acute care to rehab and then into community reintegration. And it was to address some of the gaps that happen in transitions for older adults, again, who are also living with other chronic conditions, receiving rehabilitation. And the goal again was to support self-management. So we could probably do much longer presentations on both of those interventions, but that's just a high level summary. Okay, now to the meat of it. So this is the process that we have been undertaking for the scalability assessment in both of the projects. As research projects, the process took us about a year in both cases, and we used multiple methods. So we started with document review. So the research team, we looked at research literature, best practice guidelines, anything we could find, provincial health policy, and publications. And then in the stroke study, because we were working with the community rehab teams, we also looked at all of their program documentation to understand how they were delivering care, like their assessment forms and referral pathways. In both studies, we formed working group meetings and had diverse membership. So in the diabetes study, the working groups included researchers and patient partners who were part of the whole program of research, members of the study's governance structures, such as the community advisory boards, the partner organizations, providers and leaders that had delivered the intervention. And then in the stroke study, we were working with the rehab teams, patient partners, and their managers to conduct the assessment. At the same time, we were also conducting key informant interviews to get additional perspectives on the scalability assessment. And working group members identified people they thought would be good for us to talk to learn more about the policy or political context, or about scaling up interventions, how they've successfully done that with other complex interventions. So we talked to senior government decision makers and local leaders and decision makers in the province, in both the provinces we were conducting the study in Ontario and PEI in the diabetes project. And then in our current project, we were talking to people outside of the community stroke team who might have some insights into scalability, hospital leaders and who had scaled up other programs before. We used the the scalability assessment tool to create our interview guide there as well for the key informant interviews. And then the last step of the assessment was to conduct the rating exercise with those questions that I showed earlier. So we did this a bit differently in both of the projects. And in the diabetes study, we were able to hold a full day event over 2 half days, where we shared information that we had collected using the scalability assessment tool. And then we have discussion. The participants would rate the readiness for scalability, and then we could share back in real time their assessments and discuss how they might, what the critical next steps would be and how they might mitigate some of the barriers that they had identified. And that was a really useful exercise. In our current study, we're moving a bit faster because the rehab team, we could only kind of pull them away in short bursts of time because of their clinical caseload. So we included the rating exercise during one of our working group meetings, and then we shared it back after the meetings were finished. And people could also complete their ratings offline after the meeting as well. So after we collected all of this information, we were kind of analyzing it as we went, and taking the key findings and key learnings and putting them into kind of a working document of the intervention scalability assessment tool. So summarizing everything we'd learned by domain. Yeah, so as I said in that in our diabetes work, we were able to do the readiness assessment in real time and share the results back to participants so that they could discuss them. And the developers of the tool have also created a way to visually display the results of the assessment, and I'll show that to you on the next slide. Okay, so hopefully that shows okay. So this is called a radar plot that has the 10 domains of the intervention scalability assessment tool. And this one is showing the results of the assessment that we did of the Community Partnership Program for Diabetes in Ontario. So they have an Excel document. We plugged in people's ratings to generate this. And again, the scale is from 0 to 3, with 3 signaling a higher degree of readiness, and 3 is kind of towards the outside of the circle. So you can see here on the plot that the participants rated the scalability of this program quite high, between 2 and 3 on average for most of the domains. And while I'm just showing you Ontario, this was also true in Prince Edward Island, where we also did the assessment. And you can see here they A1 here up at the top, they identified that diabetes among older adults and multiple chronic conditions is a significant problem that warrants scale up of the program to address that population's needs. They liked the intervention and thought it was reasonable and would meet the needs of older adults. As we kind of move down to the bottom, the A4, the evidence of effectiveness, was rated lower because in that particular trial, there were no statistically significant differences between the intervention group and the control group. But we had consistent positive qualitative results from older adults and providers about the program. And they also discussed why that might be, and had some ideas about targeting who might benefit most from the program. Over on the other side, you can see around sustainability and implementation infrastructure were also rated a bit lower because of concern about obtaining and securing dedicated funding for this type of program. So our work on the stroke rehabilitation is still a work in progress. So I'll just show you the preliminary results here from one site. And what strikes me here is that it's not it's not as highly rated. It's not a nice circle on the radar plot like the previous slide. And the main concern here from this rehabilitation team, again, was that implementation infrastructure, the delivery setting and workforce, how could they add in the program to their usual care with existing staffing? And they felt that without designated sustained funding, that would not be possible. So that's what we're seeing on that one side. And they also had many suggestions for adaptations based on their local context in this program that they wanted to ensure, for example, that it was a hybrid, that there would still be in-person contact and not exclusively virtual, for example. This is kind of a high-level snapshot of the results from the scalability assessment of the Community Partnership Program for Diabetes in the two provinces. And this was kind of the punchline at the end of the scalability assessment that they wanted to determine who might benefit most from the program, start the scale up with these priority populations in a phased, staged horizontal approach. And to start where people were interested and ready to go and had the existing infrastructure, and then to test it from there and learn for further targeted scale-up efforts. So that's how it kind of all came together. For the transitional care stroke intervention, we haven't finished this level of analysis yet, but I'm hopeful that the results from each site will identify factors that can help and hinder scale-up, that each program might see themselves in one of the 3 sites that we did the assessment with. So stay tuned. That's September. We'll share those findings. So just I want to take probably 5 or so more minutes to talk about some reflections I've had in conducting these scalability assessments, and then I'm really looking forward to talking with you all. But for me, I see these assessments as a way to bridge that knowledge to practice or evidence to practice gap, because I think the results of the scalability assessment can help with knowledge mobilization, not only by communicating program effectiveness or impact, but also giving people really pragmatic steps on how to translate a program that was demonstrated to be effective in research into their local context. And by designing research programs with scale up in mind, I think it can facilitate sustaining the promising practice, particularly when all interested parties are included in the research enterprise. So older adults, their care partners, health and social care providers, policy and decision makers, and researchers for this multi-directional flow of evidence, so that the research evidence is informing practice, but we're incorporating the evidence base from practice into the research evidence base as well. And I think this is really important, particularly in the implementation and evaluation of these types of complex integrated programs that are spanning multiple sectors in the health system as well as community. So now that I gave my plug for the scalability assessment as a useful research tool, we've certainly had some challenges in going through this process. And I've pulled out a few that we can reflect on and talk about. But the first one is, how local is local? Like where to start the assessment with the diabetes work. We initially hoped to assess scalability at the national level for the community partnership program and think about a national scale-up plan. But we quickly realized that the provision of diabetes care was different, not only at the provincial level, but at the city level too, or neighborhood level. So we produced an assessment at the provincial level, but this included making considerations for the scale-up plans at the local community level. I see Helen out there, Helen Young, for example, in Scarborough. They wanted to account for the very unique needs of equity denied older adults in that neighborhood. And this, how local is local, has been really evident in the stroke study as well, where access to stroke rehabilitation, just access, remains a significant challenge, particularly in Northern Ontario. So they're not ready there to enhance services until they have solved their access issues to start. Another good question is how to optimally engage patient or citizen partners in the scalability assessment, because the tool that we use, the intervention scalability assessment tool, and all the scalability assessments out there that were reviewed by Dr. Ben Sharif and all, didn't include any patient partners in the development or validation of these tools. But we had patient partners that were involved in both of these studies. So we had them participating in the assessment. And we found that across the board, actually, for a lot of the participants, the language and how some of the questions were posed limited understandability by patient and provider partners. So when we came to the stroke study, we really tried to simplify the language in the assessment questions, and we hope that that didn't change their utility. And it was really critical to have patient partners as part of the scalability assessment, because while we had consensus across a lot of the domains, the patient partners always brought different ideas to the table, and it really deepened the level of the assessment. I have a lot of questions. How much adaptation? When we were during discussions related to fidelity and adaptation and reach and acceptability in both projects, many adaptations were suggested to both programs. So then this got us kind of fretting as researchers, because we started thinking, well, what if it's adapted too much? Will it still work? Should it be scaled if it's too far away from what was originally designed? So and one of the key messages I think I mentioned earlier in the diabetes project was participants wanted to identify a target population based on their knowledge of local community needs. So for example, in Prince Edward Island, they wanted to focus on high users of the healthcare system, but we didn't have the evidence that that was a population that would benefit the most from the program. But going back to that kind of multi-directional flow of evidence, that accumulated practice and service evidence from our partners that was contextually bound, I think really merits full consideration as projects or programs leave the testing phase and move on to live in the real world. And then finally, how to continue to monitor. This is a really key part of the scalability assessment. But we found in both studies, again, that participants couldn't really identify an existing mechanism that was in place where they could kind of monitor the ongoing quality or fidelity of the program. So in the trials or the studies, there's a budget that allows for the assessment of patient outcomes in addition to or patient outcomes related to the new program or intervention. But this level of monitoring is not built in everywhere in usual practice. So there's concerns that it might not be feasible to continue to learn and monitor the program, but it's essential that they can collect information and use it clinically, but also use that to assess how the program is working and make changes as they go. I think I'll pause my reflections here because I'm very interested in talking with you all about your experiences and thoughts on scalability assessments. I'll just point to the references here regarding the two programs, as well as Milat and team on their intervention scalability assessment tool and that review of tools. And I don't know how we'll share this, but we'll figure out a way to share. These are some helpful resources that we found along the way to the tool itself, how to build out those radar plots for discussion, and some really neat examples where other researchers have used the intervention scalability assessment tool to with other programs. And then I have a link to we have publicly facing reports on our scalability assessment of the diabetes programs. So let's talk.
Great, thanks so much, Melissa. That was a really insightful presentation. You were really thoughtful in your approach about sharing, I think excessively sharing information about the application of this scalability assessment to those two programs of research and those insights gained, how it was applied differently. So that was a really, really thoughtful presentation. I do want to let you know, in our audience, I'm really thrilled that everyone is here because we have such a great mix of people who we have here. So we have many of our patient and public partners. We have some of our community partners. We have many of our Embolden co-investigators and our collaborative investigators. We even have colleagues from University of Birmingham who are here. So hello, Aphrodite couldn't miss an opportunity to say hello. So just wanted to give you, Melissa, a sense of who's in the audience, because we have such a great mix of our partners and including our funders and our advisor from the Public Health Agency of Canada. So really great to have all of you here. I'm going to stop talking and see if there are any questions.
There's one in the chat, Rebecca, and
perfect.
It's for you.
For me, okay.
Can you see the?
Oh, okay. Well, thank you. You should have been here for RF's early conversation as we were waiting for people to join the line. So we have not yet done any work on scaling up or assessing scalability of Embolden, but we have been starting to think about it, which is why we thought this was a really opportune time to have Melissa come here and share with us these insights from these other areas of work that we've done affiliated with our research unit, because I thought it was a good time for us as we're nearing the end of our trial to start to think about how do we want to assess scalability and what will the process be for scaling? Do we think we want to do sort of a horizontal approach in terms of looking at how do we sort of scale in the areas where we currently are working in Hamilton, Toronto? Is it looking at other jurisdictions? What is our approach? So I think we need to start to lay the groundwork for this, because it takes time to gather all this information and move through that process. So yeah, Melissa, super timely presentation for all of us as we start to think through what our next steps are. As you know, we always said we were going to start with scale up in mind, but we now need to kind of delve, like sink our teeth into it a little bit further. So other questions, please. Aphrodite, please. Aphrodite.
Hi, I was trying to find the hand, but I thought I'll use mine instead. Thank you, Melissa, very much for your presentation. I have a question which touches upon what Rebecca just said about, we are starting programs with scalability in mind, and then we get closer to the program and then it really kicks on. From my personal experience, I see as one of the big challenges is, even if we start with scalability in mind, there is so much changing happening, political level, financial level, community level, organizational level, and which I find it as a big challenge. So we in one of my programs, we were starting with a clear plan, and a lot of things changed in the 5 years of the trial. So trying then to do the scalability, it's more or less starting from scratch to a point. What are your views on that?
I agree. That's a great question. And even in the course of like midway through our scalability assessment for this transitional care stroke intervention, the province announced dedicated funding for 24-25 for community stroke rehabilitation with a focus on system navigation. And then they released a guiding document on the key principles for navigation. So we're right in the middle, and we had to, like, I think if we redid the radar plot that I showed you, that the one on sustainability would move now because the funding has been allocated. I would love to hear other people's thoughts on this, because I don't have a good answer, because I find this so stressful that in being responsive in your research, to support partners and the getting these innovative programs out there into the world, and not be like behind by the time you're sharing your results. Oh, good, Helen has an idea.
So thank you so much, Melissa, for walking us through your slide deck. And I find this is somehow it's an effort, and I have to thank your university, McMaster University, is leading this, scaling a successful pilots. How we'll be able to spread this kind of good practice. And then you pointed out, I mean, there are several, key factors, especially earlier talk about is the political environment. So we can say this is a pros and cons, because currently depends on how we be able to grab hold of the opportunities. So for instance, now, the Ontario Health, all the regional offices encourage, for us as, for instance, community based support service providers to collaborate with our local Ontario Health teams. So if we look at, what are their priorities, the Ontario Health team's priorities, one of the good channel is the focus is on developing collaborative clinical pathways. And the pathways, they are three major, chronic disease they focus on: CHF, chronic congestive heart disease. The other is a COPD and diabetes. And all of this are vascular, vascular disease. So your transitional care, the stroke program, and also the diabetes. So basically it is on the radar screen of all the OHTs, especially for the 12 OHTs that selected to accelerate. So basically they do receive incentive, funding to develop the collaborative clinical pathway. So how we'll be able to leverage this opportunity, because you have all the evidence. So basically it's how we are going to sell this to the OHTs. And when they want to develop collaborative clinical pathways, actually it's the pathway, the journey is long. It's not just focusing on the acute care setting or the primary care setting, but also is sustainability. You talk about sustainability. And also one of the things, Ontario Health, currently they are also focusing on preventative care as well. So the two initiatives, there is the element of also preventative care, like the stroke, to avoid to have, more strokes. And then diabetes, to prevent, not to really to slow down, the vascular disease and the self-management. So all these are relevant to the priorities of the OHTs or the Ontario Health, the priorities on the clinical care pathway. And also they do also have now opened another chapter on preventative care, wellness and preventative care. So how we'll be able to really promote this to the OHTs so that they'll be able to bring us as the providers to the relevant tables, and then to really to talk about well, they are already proven successful initiative there. The thing is that scale it up, how we're going to scale it up. And definitely they have to look into the other lengthen the journey to say like the maintenance, say like the maintenance of the chronic disease, say like whether it's diabetes, CHF, or COPD. So it's the maintenance. And I think this is the timing that that even though, I mean, earlier speaker talk about it changes all the time, but it seems that this is their priority, grab hold of it and talk to more OHTs to invite us to their tables.
Yeah, I think you're, as always, Helen, you're brilliant and and right on, and I think by including them as partners right from the beginning, when things do change, and I was trying to look for the reference, like a lot of, and I can't, but I'll try to find it later. A lot of innovation happens when that window opens or the door opens, and you're like, yes, now they're talking our language. Okay, here we are. we're ready to support. So maybe. Yeah, I think it's that.
And I think the regional office, so for instance, I use example, Ontario Health Central Regional Office, they have very good coordination. Actually, they have developed a list of contact people of the different OHTs within their region and asked us to take initiative as a community support service provider to reach out to those OHTs. So the Ontario Health Regional staff, they can help coordinate this as well. So moving forward, definitely university can speak to the regional office, because I think it is also their, they want to achieve that too. So so since, I mean, they want to achieve that, so why not take hold of this opportunity?
I think those are such really important points around being agile and taking advantage of those opportunities. I think it's a bit, Melissa, of like assessing and reassessing the landscape to know, because I think if I think about those radar plots, it's a bit of a snapshot in time, and it might have been that the infrastructure and support and the funding wasn't there, but maybe there's an opportunity now. Like, so it's a bit of looking at are there changes either for good or to make it more challenging to support implementation. I just want to shift. There are a couple of questions in the chat. So one says, thanks, Melissa. You mentioned that there were positive feedback there, so you can take a look at that after. But you mentioned that there were recommendations in the scalability assessment for the stroke transitional care program, including the desire for it to be hybrid. But wouldn't this make the sustainability and pressure on the system and workforce greater, which was already something scored low?
That's a really good question, Sue. This is another not a challenge, but the tool, all of the domains are so interrelated, and what affects one affects another. So here, yeah, again in the stroke study, what just kept coming through over and over and over was the importance of relationships and knowing the local community. So in a setting like Thunder Bay, they thought there needs to be some, they were more inclined towards a hub and spoke model, where somehow they could have that the intense stroke expertise at the regional center, but then support out to communities and share their expertise with communities where they might not have a whole interprofessional stroke team. So probably I didn't explain that well. So they needed someone that knew something about stroke rehab, but someone that was in the community that knew what was possible there to continue the journey and the reintegration into the community. Did that answer your question?
I think you did. I think you answered that question. I want to just go to, there's another in the chat, and then I see if you raised your human hand, not your virtual hand. But we'll go to Heather Keller's question first. So any thoughts on how to convince decision makers on the importance of taking up a scaled intervention, even with evidence on return on investment, as well as other factors in the scalability assessment being present? This is still a challenge.
Yeah, I feel your question, Heather. What the costing piece, that initial investment, that has been a challenging discussion in our scalability assessments, because these programs did demonstrate a reduction or what's the word I'm looking for? My goodness, no net cost increase, because it was helping in other areas, offsetting services in other areas of the system, like acute care, emergency room, or primary care, or whatever. But there's that upfront, the upfront cost that it has been hard in our discussions for decision makers to rationalize, because of all the other competing programs. So I'm not sure. I don't have a good answer. Sorry, that's a terrible answer. Although I think the starting small, I'm kind of more and more inclined to kind of horizontal phased and demonstrating that impact in your local area and with your local providers, and then telling the story, and then getting others to try it out where they have that resources and that will and desire to try out something new.
And I think if I can just add in, take me
Please.
to license to add in, I think as well, it's been really important to engage decision makers early in the process. And even as we're engaging in that next step to partner with the Scarborough OHT around planning for or supporting their process for developing their integrated care pathway, when we connected with Ontario Health around that, they're actually quite interested in this issue. It seems quite timely, and I'm not sure if any are here from Ontario Health today, but I know that there were some who were interested in this process of scalability assessment. I think many of us are aware, not just in research, but on a policy side and on a practice side, that we are the land of perpetual pilots, and we want to move beyond that. And actually, when we have promising practices, really look at and thoughtfully consider how they can be integrated into current existing practice and supported by policy. So I think there's an appetite to move beyond. It's just how quickly we can do that, because sometimes we're not the most agile. Arif, you had a question. Oh, but you're muted. Please unmute.
Yeah, I would like to thank you, Melissa, for this informative presentation. Thank you very much. I want to say that I learned from this presentation that scalability assessment is done to determine the readiness to scale up a program in 2 provinces or 2 areas, for example. So this is the scalability assessment is connected with already existing program or study. Yeah, but what I'm thinking, or my question is that which is better, to carry out a scalability assessment or needs assessment? Needs assessment is not connected with the already existing program, but it is a separate based on the needs assessment of certain community or certain area. So based on the lessons learned from the already existing program, design a new program or design a new study that takes into consideration the needs assessment of the new area or new province. What did you think that it is better to carry out a needs assessment or scalability assessment? Because scalability, as you said, that it is connected with the already existing program or study.
Mm-hmm. That's a really good question. And I probably won't have time to do it justice as we come to the end of our session. But I think it's both, really, in a way, because after you've determined that we're ready for this change, then it's mapping out the plan. And I do think you're right on that it's local. Again, it's almost hyper local with the players, because there's going to be different needs in different communities. Absolutely.
Yeah, so I think that designing a new program may be different from the existing one, but it takes into consideration the lessons learned from this program to design a new one.
Right.
Thank you.
Well said. Yeah.
Great, thanks. Thanks so much for your engagement, everyone, and for all your great questions. I see people are starting to drop off as we're just running a minute over here. So I just want to, we know people might be having to head to another meeting, so just want to thank you for joining us. I will, Melissa, if you have a minute, I see there was an additional question that was posted in the chat and went to me instead of the whole group, but just really want to thank you so much for all your excellent insights and to stimulate this conversation and to help us to think through how we can apply scalability assessment to Embolden, but to other programs and supports, and how we can draw on these case examples and those lessons learned on the ground from implementation over the last few years. So thanks so much for that. So if you need to drop off, please feel free, and thanks for your time today. I will pose the question here if we're okay for just a minute, and you're welcome to stay on if you want to hear the question. So this is a question that I don't know if you'll have an answer to, but there was a question about, have you heard of cost sharing innovations as part of a scaled intervention? For example, when ED costs not realized are transferred back to other sectors where the intervention is done. I think that sounds like a beautiful thing, but I'm not sure if it's happened. Melissa, go ahead.
Oh, I love that. Tell me what it was called again, Rebecca. I'm not aware of this.
Of sharing interventions, so cost sharing interventions as part of a scaled intervention. So where we realize cost benefits, let's say in the hospital sector, and where it gets transferred back to the community sector, for example, where those interventions take place.
Neat. No, that sounds brilliant. It sounds a bit like bundled care, but better because it's it's putting it's sharing the supports.
I see a big nod from Helen over there. Helen, it sounds like you'd support that kind of cost sharing bundled care agreement where the costs actually come back, right? Yeah, go ahead, Helen.
Actually, it is interesting because I really embrace, I mean, university academic have done such a good, job, researching and already proven, say, like telling us very successful, proven, effective models, approach, doing things. So the thing is that I'm thinking is that somehow we should say like map out all the different opportunities so that we have a checklist of different opportunities. So the opportunities is not just OHTs right now. They are asking, oh, go and work with your community partners, different sectors to map out the collaborative clinical pathway for congestive heart disease, because this is one big opportunity, diabetes, chronic disease management. The other is that they are also asking right now, I am seeing Ontario Health Regional Office asking us, what are the opportunities to help them address ALC, alternate level of care, and also down the road to prevent people, reduce the opportunity, say like to visit emergency department or a readmission to hospital. So basically for those who have strokes, those who have diabetes, all these will somehow, if we have a better practice, community of practice. So we'll be able, not immediately, but down the road, definitely will be able to help them to reduce, the visits to the ER or readmission to the hospital. So the Ontario Health, they are actually exploring into the different opportunities, and they form also advisory tables, access to provide ideas. So one of the things yesterday, I just finished attending a table is ALC tipping into ALC opportunities whatsoever. So one thing is they talk about, okay, let's find out the data first, data. So I don't know, say like whether for university, say map out the data, say what are the opportunities, say like the opportunities. So because I'm thinking community support services, most of us run adult day programs, and many of our adult day programs are stroke patients. Stroke patients, and they are having multiple like comorbidity, mixed conditions. So if we add another element to the adult day program, say like because somehow we also, so for instance, our organization, we run say like 3, 4 actually adult day programs. And different days, we have different cohorts of attendees. So whether they have more like a dementia or they have stroke, so that will bring in the relevant therapists, say like to come in. So for them to say like to have some maintenance activities. So chances are many of them are stroke. And stroke also comes with somehow the cognitive impairment, etc., different stages. So what I'm trying to say is that definitely we need that kind of, if there is the hybrid model, why don't adult day programs, we import those hybrid models, because we cannot, and not everybody can afford to come to the adult day program every day. So if there is a hybrid model for days they are at home, we'll be able to extend the transitional, say like your stroke, program to them. So what sort of elements that will take for us to practice, implement that. So I'm thinking there are tons of opportunities that we'll be able to leverage on this, all these learnings. And so it's to find the right platforms to talk to the different, say like groups, tables, and adult day programs providers, assisted living providers, say like, because assisted living, Ontario Health is looking at adult day programs, and assisted living will be the two major community support programs. Probably will be able to keep more seniors aging at home or aging in place. So definitely there are tons of opportunities, and the thing is to really to find the right group of partners to talk to. And then I think the funder is also looking for opportunities too. So how, when they fund all these programs, how those programs can maybe say adapt a little bit, so that it will say like give them a little bit more capability or functioning capacity to keep more, say like seniors, to make it more functional, the programs more functional, meeting the needs of the clients, the seniors, and the caregivers. So I see there's lots of opportunity there.
I agree, Helen, and I think I was just scribbling lots of notes. I think it's packaging and sharing these important lessons that we've learned and pulling those threads through, that these integrated programs, the concepts, the partnerships, the relationships that could work for all.
And I
all
think
sorts
the OH regional staff, they are keen, they want to know too. So I think should liaise with many of those Ontario Health regional staff and speak to them. They are also looking for solutions too.
Yeah.
Yeah. And I think the more we partner together, it's through those relationships and through those networks that we're able to, I think that we're going to be able to move forward with hopefully support for implementation. Thanks so much for joining us, everyone. Helen, you're always a champion of older adults in the community. We have many champions on the call today who are really advocating for better support for older adults in the community, helping people to maintain their independence and stay living where, in their desired community or in their desired home. So thanks so much. I hope you enjoy the rest of your day, everyone. We will be, has been captured. So if anyone wants to go back and remember any of these great insights, it will be available for you and hosted, I believe, on the Collaborative website and likely on ours in Embolden as well. So thanks, everyone. Melissa, a special thanks to you. Really great presentation.
Thank you. Thanks, everyone. Bye for now.